Thanks very much to the organizers for inviting me. It's always a privilege to speak to parents. We learn so much from the parents. During the course of the day, you've heard a lot about the advances that have occurred, both in diagnosis and in specificity, and improved survival of children with neuroblastoma. Not to say that it's perfect, but what that has meant is that there's a responsibility amongst the oncologists to ensure that the quality of life of the survivors is as good as possible. So whereas in the earlier years there was a push to maximize the cure regardless of what side effects there were, today we still want to get a 10 out of 10 cure, but at the same time we're aiming to minimize the cost in terms of chronic health problems which are associated either with the cancer or its treatment. Now, what you've been hearing about for most of today is really what we call the first season of survival, the acute survival during which there's diagnosis and treatment, during which time we monitor for cancer recurrence. At the end of the treatment, which is variable for different patients, we move into the second season, which is the post-treatment surveillance, where we're looking for the possibility of tumor recurrence. What I'm going to emphasize today is the third season, which we regard as permanent survival. This is a period where the risk of recurrence of the tumor has decreased, and the emphasis of our treatment is now on doing surveillance for any late effects so that they can be diagnosed early and intervention given. And it's a period as well where we aim to educate the survivor and the parents to become advocates for either themselves, the survivors, or their children, to ensure that they move through the health system, obtaining the care that they need, but also emphasizing, and I'll speak more about this later, what healthy lifestyle attitudes can be adopted that are known to decrease the severity and the risk of late effects. Now, for most of the talk, when I use the term survivor, I'm really referring to someone who has survived 5 years from diagnosis. And the reason for this is that most of the studies use that. A late effect we define as a problem which is related to the cancer or its treatment, which may persist from the time of treatment or develop 5 or more years from diagnosis. So we're not referring to the fever and neutropenia and problems that you encounter while on treatment. On that fateful day when you met with the oncologist and heard the diagnosis, were given the roadmap of treatment and presented with a handout like this of the side effects of therapy, there were some effects that were mentioned that were said to be late, that were said to be rare. We're going to be concentrating on those late effects over the next 30 minutes. Now, given that we're talking specifically about neuroblastoma, some of what I'm going to be saying applies to all cancer survivors, some of which will be more specific. But I just want to stress that not all patients will be at the same risk of late effects. And hopefully, as we go through the talk, you'll appreciate what I mean. So you've heard that there are patients who are treated with observation only. And as the tip of the pyramid, we would expect that they would have few, if any, late effects. There are a group who are treated with surgery only, and likewise would not be at risk for many of the issues that we're going to be talking about. Those patients with intermediate risk who are treated with surgery and chemotherapy without a transplant, likewise, will have fewer side effects. And the high-risk patients that you've heard so much about today, who undergo surgery, chemotherapy, and transplantation, and then immunotherapy, will have the largest number of side effects, and this is the area that we're concentrating on to try and improve things through research. Now, it's very confronting to hear a list of late effects, and as it was to hear the side effects of the drugs when you were first meeting your oncologist. So just a couple of points about a healthy view on late effects. Late effects are possible only when the cancer therapy is successful. Serious late effects, although we're going to be discussing them in detail now, are relatively uncommon, and not everybody sees all the late effects. There's a lot of research which is being done to reduce late effects, and that research is informing many of the new protocols that are being used up front, so that hopefully, and I'll show you that this is the case, people being treated in the modern era will not suffer the late effects that many of the patients treated in previous eras had to endure. And knowledge of late effects for parents such as yourselves who are advocates for your children is very important because you can help to prevent them or reduce them, and we'll speak more about that. Now, when we study late effects, one needs to appreciate that late effects may become evident only many years after treatment, and are not detectable at treatment end. And it's therefore very important that patients are followed lifelong, because we know that many of the patients will have 6 or more decades of life ahead, and that we're realizing, because we're now not in neuroblastoma necessarily, but in other cancers, following patients who were treated in the late 60s, early 70s, and seeing late effects that are preventing in their 5th, 6th decade. Graphically, I've just shown this in a young girl who received radiation to the right flank at the age of 2. Now, had we discharged her at the age of 6, we would have thought there were no late effects. But as she matured, went through puberty, and at the age of about 17, you can see that as a result of the radiation, she has a decrease in development of the muscle and the breast on the side from scatter radiation. Now, hopefully, with the techniques that are in use today, there won't be as much scatter. We're very aware of the effect on the breast, and we take every precaution to prevent that. There are a number of studies that have now shown that although there may be a number of years before late effects do appear, as I mentioned, they can continue to occur, and again, stressing the importance of continuing to be seen in long-term follow-up clinics or have a relationship with your GP so that there can be early detection of the late effects. Now, in following up the children and in asking you and them to attend long-term follow-up clinics, there are benefits for the individual survivor in that we can detect problems early, we can give advice, and hopefully we can ameliorate the late effects. There's also the benefit, which is more altruistic, that much of what we know today is because of survivors from previous eras who've continued to attend for long-term follow-up and have allowed us to have the knowledge which can benefit the next generation of survivors. And hopefully many of your children will in fact be benefiting from the knowledge that we've gained over many years of research. Now, there's a lot of research happening in parallel with the research you've been hearing about earlier today. and is guiding the decisions about the different treatment protocols. Two of the biggest cohorts, the first is the Childhood Cancer Survivor Study in North America, which since 1970, has patients treated in 1970 who are being followed. There are over 24,000. A lot of what we know has come from studies that have been published from this cohort. One of the problems is that many of the patients treated at an earlier period were treated with much more intense treatment or different treatment, and we don't use some of those techniques, and therefore some of the information is really not relevant, but we've got to use it until we have the more up-to-date information. The European groups, although I'm not sure if this is true, I've just been told that Britain's voted to leave the European Union, have been working together, and potentially the individual countries are bringing 80,000 survivors into PAN care, which will increase our understanding and knowledge of late effects. Now, neuroblastoma patients, I guess because there weren't as many survivors, have not been studied as well as some of the other survivors. There are a number of publications, and you can see that along the right-hand side here, have very small numbers. Of the paper by Toby Treher, of which we were all co-authors, had only 23 patients. But all of these have given us information, and I'll spend a little bit of time now discussing the side effects that have been coming up as common. So the effects on lung, kidney, growth, the effects on ovary and testis, the thyroid, hearing, and cognitive function. In about 2007, we looked at the patients that we were treating with high-risk neuroblastoma, and at the time we were using conditioning for autologous transplant with chemotherapy and total body irradiation. And this was similar in most centers at the time. And in fact, our survival rates were as good, if not better, than many elsewhere in the world, with an overall survival of about 60%. However, when we looked at the long-term effects in the patients who were being followed, we found that they were unacceptable, that the quality of life with the renal impairment, growth failure, endocrine problems, and hearing were really unacceptable. And we, together with many other centers, including COG, at about the same time, many of the European centers, took the decision to not continue to use total body irradiation, which was fraught with so many side effects. Now, this slide refers to patients with Hodgkin's disease, but I just wanted to illustrate that in taking the decision to stop TBI, we were nervous because we didn't want to lose the survival rates, but we wanted to improve the quality of survival. A similar thing happened with treatment of Hodgkin's disease, where we used to use radiation to the chest wall. We changed to chemotherapy only, and in fact, there was no statistically significant difference between the two groups, but the number of second cancers fell significantly. And we hope that this is what we'll see as the analyses of the modern era treatment come through. Now, we don't have results of the busulfan-treated autologous transplants yet, but just to show you this information from a similar study with patients with leukemia who, when we compared busulfan with total body irradiation, we showed that there were fewer late effects in those who were treated with busulfan, and they were generally less severe than the total body irradiation treated patients. So, to move on, we've alluded to the term cure. What do we actually mean by cure? The best way I find of answering this is to look at patients who are alive and disease-free at 5 years, so who are, by definition, survivors. And please look at the figures on the left. If we look at 15 years, so this is now 15 years from diagnosis, or 10 years from the 5-year disease-free state, over 90% of the patients will be alive and free of their disease. So there are some deaths that occur, but we're looking at relatively small numbers, and this isn't for neuroblastoma. This is from the Childhood Cancer Survivor Study, looking at 20,000 patients with various types of cancer. Now, we looked at the patients treated in my center, the Sydney Children's Hospital, and there were just under 1,000 patients at the time. Of the 5-year survivors, at 15 years, the causes of relapse were relapse of the primary cancer. So although we say it's rare beyond 5 years, it does happen. Don't be put off by that figure. Remember, we're talking about a small number, so the actual percentage is less significant. What we also saw, that these were patients treated from the 1970s until 1999. There were deaths from treatment-related complications, which by changing the treatment, we hope that we've decreased. There were second cancers, which were comparable with the reports from the Children's Cancer Survivor Study and from the Scandinavian hospitals. And about 10%, which was a very small number in absolute numbers, had died from motor vehicle accidents, drugs, suicides, very similar to the general population. So no increase. At 20 years from diagnosis in our study, the incidence of second cancers, so those are cancers that are different from the primary neuroblastoma, was 3.5%. And if any of you were at the presentation yesterday, Mark Applebaum presented an updated result from the Childhood Cancer Survivor Study showing that patients who are treated as low risk or intermediate risk had a very low incidence of second cancers. Low risk at 10 years was, I think, 0.35%. Intermediate risk was 0.5%, and the high-risk patients was 1.8%. So we are aware of them. We do warn about them, and we do everything that we can to try to prevent them by changing the treatments. We also, as part of the education about long-term follow-up, educate the survivor or the parents to be aware that if there are symptoms that don't disappear, that persist, a change in the voice, a change in bowel habit, weight loss, a cough that persists, that err on the side of being seen by your healthcare practitioner. But the good news is that Greg Armstrong earlier this year published this study from the Childhood Cancer Survivor Group again, and what it showed was that with each advancing decade, there's been a decrease, so this is the 1990s, in death from disease recurrence or progression, and there's also a decrease in deaths from health-related causes. So as we've learnt from our study on the survivors, we've been able to implement changes in the treatment which have resulted in decrease in complications from the treatment. Of course, we're not only interested in deaths, we're interested in chronic health conditions and quality of survival. So from the studies that have been done in childhood cancer generally, so this is not neuroblastoma, the areas of physical complications that we look out for is damage to any vital organ, and I'll discuss that in more specific detail in relation to neuroblastoma in a second. We look at growth and development, and this can be linear growth, it can be skeletal maturation. We're interested as well in intellectual function, emotional development, and sexual development. Of great importance to everyone is fertility and the health of the offspring, and we'll touch on that. And I've touched on the second neoplasms, second cancers. We're, of course, also very aware of the psychosocial effects of treatment, and I'll go into a little more detail later, but just to say that we do follow up patients in terms of their mental health, with depression, post-cancer anxiety, social interactions, the interaction with their family and with peers. Is there social withdrawal or isolation? Are they able to live independently? Do they get married? Are they able to have intimacy? Academic follow-up is very important, and most long-term follow-up clinics would spend a lot of time looking at how children can be helped. Now, of course, 5 years is quite arbitrary, so many of these things would actually start before the 5-year mark. And as I'll mention again, we're very aware that lifestyle choices can cause some of the late effects, including second cancers, to be worse, and therefore it's very important that healthy living is encouraged, and that's part of what is done at the long-term follow-up clinic. Now, not all the complications, of course, are as severe. Some I call life-altering, and these include infertility, hearing loss, short stature, and these are the majority of the late effects. The life-threatening ones, such as the effects on the heart or the lungs or high-grade second cancers, are far less common, but are the ones that have influenced changes in treatment over the years. So when we look at how we're going to follow up an individual patient, we look at the specific therapy that they've been given. So we don't follow all leukemics in the same way, because over years the treatment changes. And likewise, a patient with neuroblastoma is followed according to the risk factors that we can predict based on the individual treatment that the child has received. Now, I heard when I was sitting at the back in Donna's talk this morning, something about parents of neuroblastoma patients being unique. The side effects in the children who've been treated for neuroblastoma, by and large, are not unique, although we do recognize that as a group, children with neuroblastoma are treated at a younger age, and we therefore see some of the problems, and they're also treated at a younger age with multimodal therapy. So we did a study, for example, that showed that you can get benign growths called osteochondromas on bones in children who've had total body irradiation. And those only occur in children treated under 5 years of age. We didn't find any in children treated over 5 years of age. Now, in order to determine what treatment the patient had and what late effects should be looked for, all units, and I'm just showing one from my unit, but each unit will have a health summary, a health passport, a survivorship care plan, which is provided to the family. And that can be more detailed or less detailed. We've taken the option of having it as 1, maybe 2 pages, so that the family can carry it around. The survivor, when older, can have it in a wallet, and if he goes to a new doctor, can present it to him. As parents, you all think that you will remember each dose and every drug that was used, but trust me, I see the families in long-term follow-up clinic, and fortunately, you don't remember that. So we give a breakdown of the stage and the risk factors. We then summarize very briefly the treatment dose, the treatment given, and give only the doses of those drugs where the late effects that need to be followed are dose dependent. So the amount of cyclophosphamide is significant in terms of the risk of infertility and second cancers. Likewise, busulfan can be used in lower dose, but when used for conditioning in autologous transplants is used at a bigger dose and has different implications. The biologicals, the surgery, and what radiation has been used. And then based on that, we develop a health prescription. It'll be different in each of your hospitals. So based on the treatment that this particular patient had, we would be recommending that the heart needs to be followed, that there needs to be testing of the thyroid, that we need to look at the blood sugar of the patient, the bone density, look at the bladder, the skin, hearing. I'm going to go into these, so that's why I'm rushing through them. Looking at the teeth and looking at whether the child is going through puberty normally. The Children's Oncology Group, and you've heard a lot about them, have developed screening guidelines that are available to everyone. There are a number all around the world. Different countries have developed their own guidelines. They are available on www.survivorshipguidelines.org if anybody wants to access them. They are detailed. They go into each of the drugs and each of the combinations of drugs, each of the radiation treatments. So I've just chosen as an example here the alkylating agents, which includes busulfan, cyclophosphamide, melphalan, which many of the children on high-risk treatment will have received. The potential late effect that is highlighted in this particular one is ovarian dysfunction, and the periodic evaluation that is recommended is at puberty. One needs to do blood tests to make sure that the child is going to progress normally through puberty. And importantly, for counseling of children, the side effects can be aggravated by smoking. So again, that would be part of the education at a long-term follow-up clinic. Now, radiation, if it's total body irradiation, which I don't believe anybody's using at the moment for neuroblastoma, it's one thing, but if it's local radiation, there's actually a guideline for each area because radiation only affects the area on which it is beamed. So again, we specifically look for each patient at the area that has been treated. Now, if we look at some of the specific organ toxicities, one of the commoner ones that we see is ototoxicity. It was seen previously, unfortunately, it still is being seen with the use of cisplatinum and carboplatinum, and it can be aggravated by antibiotics such as gentamicin, which in our unit we're trying to avoid so that we're not putting that on top of the chemotherapy. It can cause hearing loss, it can cause ringing in the ears, tinnitus. We start, as you would all know, screening for it during treatment, which is different to many of the other late effects, and it may mean that there needs to be amplification with hearing aids, and that it's very important that there's noise avoidance, which people often don't appreciate. Now, although we treat patients in a group on very similar treatments, some patients develop severe ototoxicity and others less severe. And what we've discovered just in the last couple of years, and this was a study that we collaborated with St. Jude Research Hospital on some brain tumor patients that we were treating, that in fact there are people who have a mutation in a gene, the ACYP2 gene, which puts them at increased risk of developing ototoxicity. And we're hoping that as we become able to give more personalized medicine, that we may be able to screen for mutations like that and then try to avoid cisplatin or ototoxic drugs. It's a difficult balance between compromising cure and avoiding late effects. But that's the direction in which care is going. Another common late effect, because of the young age at which children are treated, is the effect on the teeth. Chemotherapy given before permanent dentition has erupted is well known to cause problems. There's an increased rate of dental caries, but there's also the absence of development of teeth, and sometimes the roots are very small. There's also changes, and you see dental ridging and pitting. Now, why this is important is that if the tooth doesn't develop, it's important that you don't go to an orthodontist who says, there's crowding, I need to pull those primary teeth to allow the jaw to develop, and then find that there's no adult tooth to come through. Because the longer you can keep the primary dentition, the more mature the jaw is. And if you don't have a tooth pressing down, you may be able to keep that primary tooth into your 20s, at which stage it's quite easy to do an implant. So parents and survivors need to know that. Busulfan and melphalan, as well as TBI, can cause stiffening of the lungs, or so-called pulmonary fibrosis. It's a relatively rare side effect, but it is something that we will screen for with lung function tests if the patient has had those drugs. Again, absolutely vital that the patient doesn't smoke, doesn't inhale illicit drugs, because that's going to put them at increased risk. There are a number of endocrine problems that we recognize as occurring with treatment. Underactivity of the thyroid was very common in patients who received TBI, and it's still seen in patients who are treated with chemotherapy only. And there's been a suggestion recently that MIBG, not therapeutic as you just heard, but diagnostic MIBG, in spite of the fact that we're giving Lugol's iodine to protect the thyroid, may play a role. So it's something that would be screened for in the long-term clinic. With TBI, short stature was very common, and is still, TBI is the strongest cause, but we do see some degree of short stature, although it's significantly statistically less, in patients who haven't received TBI. And we think that this might be due to the chronic effects of a period on chemotherapy. If there's an irradiated bone, that might interfere with growth. And there's been one paper published from the group in Philadelphia that has suggested that retinoic acid may cause premature closure of the growth plates of the bone. And based on that, it still needs to be validated. We will be looking and advising that patients should be followed and may need an X-ray to look at the bone age, because if that is going to be seen now that patients are receiving retinoic acid on a regular basis, there are ways of stopping closure of the epiphyses and giving growth hormone to allow additional growth. But this is early work, and we'll have to see whether it's validated. Both TBI and the alkylating agents such as busulfan and melphalan, as well as abdominal irradiation, can affect the ovaries. With TBI in particular, and to a lesser extent with busulfan, there is a percentage of girls who may have delayed puberty. Most will actually start going through puberty, but may need medication to actually allow them to progress fully. There is also the risk of premature menopause amongst people who've had a normal menopause, but been exposed, menarche, started periods, but have been exposed to these agents. And infertility is a risk, which I'm sure was discussed with you when treatment was being decided. So at the long-term follow-up clinic, from the age of around 13, we would normally do blood tests so that we can estimate whether a girl is going to go through puberty. The good news, and this has been reported now in many studies, that if the patient remains fertile, the offspring do not have a greater risk of congenital anomalies or of cancer than the general population. Now, in males, there are two different types of cell in the testis. There's the Leydig cell, which produces the male hormone testosterone. And although it can be affected by busulfan and melphalan, it usually isn't affected to the point that there's any problem with the boy going through puberty. With a combination of radiation and the drugs, that might mean that androgens are needed. However, both TBI and busulfan and melphalan can affect the germ cell function of the testis and cause infertility. Not in everyone, and that's something that we would follow. Now, in patients who received TBI, this is a study that we did, it included a group of neuroblastoma patients. Those who'd received TBI had a high incidence of becoming pre-diabetic, having an insulin resistance. We saw it to a much lesser extent in those who weren't treated with TBI. And the importance of knowing this is that it's important that the patients exercise, remain fit, and watch their diet and do not become overweight, because that can decrease the risk of the prediabetes, and prediabetes predisposes the survivor to heart problems, and now there's a suggestion also to second cancers. So that's something that we would monitor for and educate about. Cataracts, which is an opacity of the lens, which you can see here, were very common with TBI. It does occur with busulfan, but very much less commonly. If it does, fortunately, it's a side effect that is easily remediable. The lens can be replaced. But it's something that we would watch out for. Now, hot off the press, there don't appear to be any significant late effects of immunotherapy. Their effects acutely, but there haven't been any proven effects. Obviously, we'll need to follow the patients for longer, but to date, there are none that are documented. So let's just touch on some of the organ toxicities and why we will follow them and what we will do. We also are very aware that any cancer experience can have an impact on the psychosocial development, not only of the child, but of the whole family. And in fact, I've put this picture in because it shows anger, and it was drawn by a sibling. So don't forget that the siblings are the people who are often not remembered in this whole experience. And often at late effect clinic, we hear about the problems for the siblings. In a study that one of my students did, we showed that 5 to 30 years after the cancer experience, 9% of survivors, 18% of mothers, and 10% of fathers were being diagnosed with post-traumatic stress disease. But equally, up to 70% of the sample showed positive growth as well. And the greater appreciation of life was the most endorsed attribute from all the groups, the survivors, mothers, fathers, and siblings. So we're now trying to prevent this. We have a study called Cascade in our unit, which is an online platform so that we can overcome the tyranny of distance. If anybody would be interested, it's 4 weekly meetings with a psychologist online. You're very welcome to contact Claire Wakefield, whose details are given there. Now, I mentioned earlier that there are a number of things that can be done to try to decrease the severity of the late effects. Early diagnosis is one of them, but health behaviors are also important. Alcohol can increase the toxicity of the drugs on the esophagus, on the liver, the risk of second cancers. Smoking certainly increases the risk of heart disease in people who have a risk and at a younger age. It is also associated with second cancers. Now, we could say that we've been successful in that when we surveyed our survivors, only 13%, and these were all over 18, they were older survivors, compared to 19% in the general population. But having said that, 13% in a high-risk population, we believe, is excessive, and it's important that people are aware of that. We emphasize the importance of avoiding sun exposure. People who've been exposed to a number of chemotherapeutic agents are at increased risk of sun-related damage, not only melanoma, and should be careful when exposed to the sun. And I've mentioned earlier the importance of diet and exercise. Now, it's absolutely vital, I said this at the beginning and I'm going to stress it again, that the survivor and the parents are knowledgeable about the treatment because you need to help the survivor navigate the healthcare system. And unfortunately, there are many people who don't appreciate that having been treated for cancer carries certain increased risks. And there's the risk that you can present to a healthcare practitioner who may not take into account the earlier exposure to radiation or chemotherapy and not appreciate that the symptoms may not be the same as someone who's never been through that treatment. There are a number of handouts that are available for people who are interested. The Children's Oncology Group, again on www.survivorshipguidelines.org, has made about 150 different guidelines available, written in lay language and covering virtually all the aspects of survivorship care. We hand them out to the patients on their risk stratification. One of the other roles that the survivorship clinic fulfills is advocating for survivors. Many of our survivors have been discriminated against in terms of insurance, in terms of entry into certain professions. Here we wrote to Peter Cosgrove, who was then head of the Defence Force, because a patient who'd been treated for Hodgkin's disease was denied entry, and based on that they changed the regulations and took into account that in the modern era it would be quite acceptable for someone who has survived to enter the Defence Force. So, to stress again, not all patients need the same degree of intensive treatment. Low-risk patients, as we defined earlier, who've had surgery only or low-risk chemotherapy, can be discharged once they've gone through puberty and are of an age where they can leave the children's hospital to be followed up by their general practitioner. Those patients who've had moderate risk disease may well, if they're clinically well, be able to be followed in a low-risk clinic. And the high-risk clinic, for those who've had high-dose alkylating agents and drugs which may cause late effects many decades later, would be best followed in a resource-intensive follow-up clinic, which most of the, well, I can say all of the 11 oncology clinics in Australia and New Zealand provide. There is a problem at age 18 where patients need to be transitioned, and that's something that we're working with primary care physicians and with our adult colleagues to ensure that there is some form of follow-up beyond the age of 18. It's vitally important that every child has a general practitioner. During treatment, it's very easy to cut the ties with the general practitioner. 34% of the 600 survivors whom we have received questionnaires back from around Australia do not have a GP. The GPs are keen to be involved. It's important that we communicate with them, and it's in the interests of every survivor that they have someone who understands and who can support them. One of the problems that right around the world people complain about is that we know that, as I've shown, that the risk of late effects increases with time. Attendance at long-term follow-up clinics tends to decrease, so that many patients are not getting the type of surveillance and the type of care that is needed. And that's something that we're working hard on to try to improve. So in summary, we believe that today cure is not enough. The whole team, not just the oncologists, are aiming to have survivors who are free of handicaps caused either by their disease or its treatment, who are able to keep up and compete with their peers, who are employable, insurable, and able to take their rightful place in society. Thanks very much.